Hi, this is Robert Spiera at the Hospital for Special Surgery in New York, and I'd like to talk today a little bit about mimics of polymyalgia rheumatica. We all know polymyalgia well, and we encounter it in practice as it is among the most common inflammatory diseases of people over the age of 50, and even more so as a new onset inflammatory disorder of people over the age of 70. But that's a group of patients in whom many different conditions, problems can contribute to similar symptoms. Polymyalgia is perhaps the most quintessentially clinical syndrome of any of our rheumatic disease. There's no single specific lab test or biomarker that defines the disease, but rather it's a constellation of signs and symptoms supported by some lab features that helps us know that this is what the patient has. And indeed, going back to 1966, when my father was one of a few authors on the first description of polymyalgia rheumatica in the US literature, in arthritis and rheumatism at the time, they had to make the argument that this indeed was a syndrome unto itself. So we kind of know what it looks like. It's people often over the age of 50, even more so over the age of 60 or 70, with generalized aches and pains and feeling systemically unwell, often involving the shoulder girdle, and often with findings on labs suggesting inflammatory disease. But there are other things that can present that way, and we always have to think about that. And we have to think about the fact that not only are there mimics of polymyalgia, but polymyalgia can coexist with other morbidities which may contribute to similar symptoms. And when I think about this as I approach the patients, I kind of think in categories. So first of all, there are degenerative or mechanical musculoskeletal issues that can mimic polymyalgia, of course. So patients with rotator cuff injuries can present with bilateral shoulder pain, and they may say, I feel worse overnight or moving in bed. Patients with osteoarthritis of the neck or generalized osteoarthritis can present with generalized achiness, which is the hallmark of polymyalgia. Patients with fibromyalgia, which we don't think a lot about in this age group, but it's a prevalent disorder, maybe 10 to 15% of the general population. There can be fibromyalgia in this population, and fibromyalgia can coexist with fibromyalgia. That can be very tricky. We also know that among the inflammatory conditions which really polymyalgia is an inflammatory condition, there are other inflammatory conditions that we would think about when evaluating a patient presenting with this types of general achiness, but also, let's say, markers of elevated acute phase reactants on laboratory testing. So rheumatoid arthritis often presents at a younger age, but it can present at an older age. And polymyalgia rheumatica versus is this rheumatoid arthritis of later onset can be very hard to tease out. And it's sometimes only over time that that can tease itself out, particularly recognizing that perhaps 10% of patients with polymyalgia rheumatica can have tenosynovitis in their hands or wrists or knees. So it can look very much like a primary peripheral inflammatory arthritis. Generally, you won't see the presence of rheumatoid factor or CCP. And almost by definition, you will not see evidence of erosive disease. But that would be an important distinction to think about, and usually is very doable between checking the appropriate labs and sometimes radiographs. There's the entity of RS3PE, relapsing symmetric synovitis with pitting edema, which is a very similar entity on some level to polymyalgia in that there are elevated acute phase reactants and puffy hands. And it also responds well to steroids, but it generally doesn't have the shoulder predominance of symptoms, nor does it have the association with giant cell arteritis. And of course, giant cell arteritis can present with polymyalgia rheumatica symptoms, but I wouldn't really call that a mimic. I would call that a polymyalgic presentation of GCA. So we would want to think about GCA in a patient in whom they are presenting with polymyalgia, but let's say not responding to low doses of steroids. And of course, we always want to ask about signs or symptoms of polymyalgia. And finally, there are non-inflammatory and non-primarily musculoskeletal disorders that can present with non-specific polymyalgic symptoms, such as generalized muscle achiness, fatigue, etc. So definitely endocrinologic disease can present that way. I usually check thyroid function studies in these patients. Often there are signs and findings on exam that might point to hypothyroidism, but those tests are easy to do. And in the context of the very elevated sedimentation rate we might see in these patients, especially recognizing that there may be underlying mechanical issues contributing to pain, I'm often checking a serum immunofixation, thinking about myeloproliferative disease, particularly if the patient has cytopenias or even significant anemia beyond the mild anemia we often suspect for polymyalgia rheumatica. And one of the interesting tools we use to help us tease out whether it's polymyalgia rheumatica or not, even though it didn't emerge as discriminatory in the classification criteria, is the response of patients to relatively low doses of corticosteroids in terms of us feeling more confident that it's polymyalgia. But that is not a perfect test. And there are patients who can feel much better with degenerative arthritis or other systemic disorders on some dose of steroids. And of course, always the reason we want to exclude mimics of any disorder is to be as specific as possible diagnostically. Number one, not to miss a potentially dangerous or otherwise treatable cause of the disorder. But particularly in this era of the emergence of targeted therapies proving effective for polymyalgia rheumatica, we really want to know that the patient we're treating does indeed have polymyalgia rheumatica. This is Robert Spiera. Thank you very much.